Hi everyone. I thought I would just make a short recording, and I hope it'll be fairly short, that goes over the systematic rhythm interpretation method. And Leslie went over this with you in class last week, but I just want you to have an opportunity to either see it if you weren't in class last week or to refresh your memory if you were and you want to go back and look at it again. So here are the basic steps that you're always going to go through every single time you see a strip. Don't think when you become an experienced nurse, you don't follow through on all these steps. You always go through them. You go through it quickly. It may become so intuitive that you're not really acutely aware of it, but you always go through these steps. And it's sort of like everything else we do in nursing. If you jump to look at one thing, for example, jump to look at the rate, and you're only looking at the rate that the monitor is showing, you may not notice that there's a difference between the atrial rate and the ventricular rate, and that tells you about what kind of rhythm you're in. You may not look at the intervals or measure them, and that's going to give you really important indicators about where you have delays in conduction or where conduction may be going through an area too quickly. That electrical impulse may be speeding through. So we go through this process systematically every single time, and it becomes very quick and very intuitive. So here's what we do, and we'll go through it slide by slide. First, we assess what's called the rhythmicity, right? So how is it regular or not regular? And we look at that for the atria, and we look at that for through the ventricles, right? So the atrial conduction and then the ventricular conduction. And do you remember when I talked about the conduction system? We see that separately on that tracing. We see the depolarization of the atria in that P wave, and then the QRS is the depolarization through the ventricles, and that's why we're able to see the difference. So step one, assess the rhythmicity. Step two, we assess the rate. We again look at the atrial rate and the ventricular rate. In an ideal world, there's always a P wave before a QRS. That means that every atrial contraction is followed by a ventricular contraction, every atrial depolarization is followed by a ventricular depolarization. But that's not always the case. So we need to make sure that that is. When it's not the case, we need to know what the difference is. And sometimes what we're looking at is the ratio of how many atrial depolarizations do we have for every ventricular depolarization, things like that. And again, week by week, we're going to go through this, so don't worry. The third step is we're going to identify and examine the different waveforms. Remember the P wave and the QRS and then the T wave. And then we're going to look at the intervals. And you remember the interval is from the start of a wave all the way to the beginning of the start of the next waveform or the complex. So if you imagine, we start with our P wave, which is our first upward deflection, typically upward, but our first deflection off that isoelectric line, and includes the P wave and back down to the beginning of our QRS complex, but we call that the R wave. So the PR interval includes that upward, or it could be downward, but that movement away from that isoelectric line, plus the interval that follows it, where we come back to that isoelectric line. We look at our QRS and we look at our QT. And for us, QT is typically a calculation, so we'll measure that, but looking at QT length is a little bit of a complicated thing to do. Finally, we're going to look at our ST segment, and we look at that because that tells us a lot about some conditions, in particular that ST segment where we have that follows remember the QRS is our depolarization through our ventricle, and then at the end of the S, so the end of the QRS complex, we should be coming back to that isoelectric line before we go up and have that T wave, which is that ventricular repolarization. That ST segment tells us a lot about whether we have some ischemia, so if we have depression in that ST segment, or we come back underneath that isoelectric line, or if we have elevations, that's where we're classically going to see an acute MI. We also can see, as we move into our T wave, if we have some electrolyte abnormalities. So that ST segment is really critical. And then finally, the last thing we do is we interpret the rhythm, name that rhythm, and it is based on all of those preceding steps. Okay, so rhythmicity. What we're looking at is our ventricular rhythm, and how regular or not, whether it's regular or not regular. And to do that, we measure R to R to R. I'm going to show you that on a strip in a second. And we look at our atrial rhythmicity. So in that, we measure P to P to P. And it's really important, again, that we measure both and that we make sure that there is a P that precedes every QRS. And there's a whole bunch of terms here. So hopefully most of our patients have a regular rhythm, and that means that the distance between every R to R to R, the distance from P to P is always the same. Sometimes we have a rhythm that's mostly regular, so they say essentially regular, but there may be a little bit of irregularity, and often we see that when people, particularly young people, take a deep breath, and their heart rate may just temporarily slow down just a tiny bit, but it's essentially a regular rhythm. An irregular rhythm, we see that in lots of different kinds of rhythms, lots of different underlying rhythms, but what we look for is, again, either the P to P or the R to R is not regular. These ones, I'm not going to ever ask you this to name these two last elements, whether you have a regularly irregular rhythm or an irregularly irregular rhythm. Part of that is just, again, you'll become really intuitive and you'll figure it out. A regularly irregular rhythm is with some kinds of blocks. We'll talk about blocks a little bit at the very end of this segment, this series on cardiac interpretation. But whether it's regularly irregular or irregularly irregular is it becomes obvious over the course of time. So I just wouldn't waste your time on it now, because it all becomes too much to remember, and it's not particularly helpful. So don't even worry about that. So is it regular? Even this essentially regular, close enough to regular is what you're thinking. So is it regular or is it irregular? That's what I want you to be able to tell me. Regular or irregular? Okay. So what we want to do is assess rhythmicity, right? And you see the strips, and there's a couple of different pictures there that are really helpful. So you can use calipers, and in the top picture you see someone has their calipers. It looks like a compass that you might have used in geometry when you were in high school. But they don't have a pencil on either end. It's just two metal points on both ends. Or what most people use is a little strip of paper. A lot of people I know use just the corner of an alcohol wipe. So they take an alcohol wipe and move it along, as long as your R to R's are not further along than what you can easily measure on that little strip. Otherwise, a scrap of paper and you're perfectly fine. So to determine your ventricular rhythm, you want to see if it's regular or irregular. And you're going to remember that QRS is the depolarization of the ventricles. So what you want to do is measure the distance between two consecutive QRS complexes, and where you measure it is at the R wave, that first upward deflection, right? So that first upward one is R. You measure from the beginning, the top of one R to the top of the next R, and you measure that by either putting your calipers on there or a piece of paper. And then you move along without opening your calipers. You move your paper along from the first, you've got the first complex to the second, and you've measured both of them. Then you move your caliper so you're at the second to the third complex, or you move your paper so you're at the second to the third complex. As you move it along, what you want to do is either see by the number of small squares, see by whether you have to adjust your calipers or not, whether those complexes, those R waves, are the same distance apart. Okay. Now, when we're looking at rate, so remember the first question was regular or not regular, and we've just measured our R to R's. We're looking to see if that's regular or not, or irregular. Second question, what is the rate, right? And we can do this in several ways. There's the 6-second method, and this is the most common method, okay? In the 6-second method, you're going to use a strip that's marked off for 6 seconds. Typically, your machine is going to show it to you, but regardless, you can either count 30 big boxes or 6 seconds is marked off on the strip. You count the number of QRS complexes, so the number of R's in those 6 seconds, and you multiply that by 10, and that gives you the number of QRS complexes in 1 minute. Okay, so if you had 6 in 6 seconds, multiply that by 10, you have a heart rate of roughly 60. If you had 7, you multiply it by 10, you have a heart rate of roughly 70. In this case, we see 8 complexes. We multiply that by 10, and we have a heart rate of roughly 80. Now, do you remember this is rough? It's an estimate. But typically it's not going to matter so much if I'm estimating that the rate is 80 versus a monitor may show me that the rate is actually 82 or 83. The rate is, there is some error built into the 6-second method, but it gives you a relative rate that gives you enough of a ballpark, a close enough ballpark that you can appreciate what that means in terms of normal rates, where the complex is initiating, and how that conduction is moving through the heart. So it's really important as well that when we calculate the rate, we look at both the atria and the ventricles. Okay, so in adults, we're going to be always looking to see if there's a P that's preceding each QRS, and we'll talk about that later, but ultimately for rate, we're looking at that QRS complex. We also can do what's called the large box method, and it's also called the rule of 300. And so what we do to determine the ventricular rate here, we count the number of large boxes, so the big boxes, not those little tiny squares, that are between 2 consecutive R waves. So again, always for rate, we're doing R to R, and we divide that by 300. So if we did, and it's easiest if you start on one that's right on a thick line. So if you look the first, second, third, the fourth complex end, you see how that R wave is right on, just about right on that heavier line. Then we count the number of big boxes, those large boxes, from that complex to the next complex. And that's going to give you the rate if we divide it by 300. So here we would say 1, 2, 3, about 3.5. So 300 divided by about 3.5 is going to give you that rate, and that's going to it's going to be about 75 or 80. It's best used if the rhythm is regular. This is a really important point. If you've got an irregular rhythm, the rate I calculate between 2 beats, like let's say the 3rd and the 4th beat on the strip, might be different than between the 6th and the 7th beat on the strip, depending on how irregular that is in particular. So the large box method, you're counting the number of large boxes and you're dividing it into 300. All right, so there you go. That just gives you the summary of them. This is also helpful as you look at the sequence method, which is the next one down. So what did we say? 4.5. So, actually look at that. If it was 4.5 boxes between the first beat and the second beat, it's somewhere between 60 and 75. So the sequence method. The sequence method is similar to the large box method. We're counting those big boxes, the darker lines, but we're just counting, down. So what we want to do is select an R wave that falls on a darker line if we can, and then we count down by those darker lines, by those bigger boxes, following this pattern. So if it was 1 big box away, the rate is 300. Hopefully we don't have a patient with a heart rate of 300. 2 big boxes away, it's 150. 3 is 100. 4 is 75. 5 is 60. 6 is 50. So 300, 150, 100, 75, 60, 50. You just remember those numbers. You memorize them. They're not hard to keep in mind. And so wherever the next, excuse me, the next R wave falls in relation to those dark lines, that gives us the number. Now remember, typically you're not going to have those 2 R waves falling on a dark line. You want to start with one that as much as possible falls on a dark line, and then count down 300, 150, 100, 75, wherever. And when you get to the next one, if it's right in between 2 dark lines, then you're going to estimate it to be about halfway. So for example, when I said it's halfway between 75 and 60. Or if it was a third of the way in, there's a little bit of a rough estimation that you can do with that, or it's between 50 and 60. However you estimate as you count down those boxes, but it's always that pattern: 300, 150, 100, 75, 60, 50. Once you get below 50, you know that you're in such a bradycardic rhythm, you need to use another method. Okay, small box method. I don't know anyone who uses the small box method because it is not, because it's so time consuming. It is very accurate, but it's very time consuming. So you want to count those number of small boxes, the tiny ones, not the bigger boxes, between two consecutive RR waves or even the PP waves, and you divide that by 1500. So you need a little calculator there. So again, it's like that one where we did we counted the number of big boxes between two R waves and divided by 300. In this case, we're counting the number of tiny boxes between two R waves, and we're dividing it by 1500. Okay, now we're going to get to the exciting part. So we've done the rhythmicity. Is it regular or is it irregular? And remember, we did that by either using calipers from the R to R to R, or using a little piece of paper marking two R's on as little notches on your paper and then moving that along. So that was your rhythmicity. Is it regular or irregular? Step 2 is the rate. We could use lots of different methods. The most common and the one we'll use in this course is the 6-second strip. Most strips are marked off for you, but otherwise it's 30 big boxes to get to 6 seconds. You calculate them by the number of R's you see there, those R waves, and you multiply it by 10. There are a couple of other methods I went through, but mostly we're going to use the 6-second strip in this course, and most of the time you're going to see that in practice. Number 3, now we look at the waveforms. So what we want to look at to see if there are normal waveforms: the P, the Q, the R, the S, and the T. All right, then we're going to move on to some other things. So let's start with P. First step is to find out if there even is a P. Is the P wave there? Yes or no, simple yes or no. P's can look a whole bunch of different ways. Ideally, they are upright, so they deflect upward off that isoelectric line, and they all look the same. I don't have some that are small, some that are big, some that are pointy, and they should be nice and rounded. So upward deflection that's rounded, and what we want to see is only one P wave before each QRS. So pretty simple, right? P waves. Are they present? Yes or no? Simple yes or no. Are they upright? Do they go up off the isoelectric line instead of downwards? Do they all look the same? Every P looks the same. They're not all different shapes. And is there one P wave before each QRS? Just one P wave before each QRS. Okay, that's what we're going to do with our P waves. Now we want to look at QRS, and QRS is so interesting, right? QRS, if you remember, P wave tells us about depolarization through the atria. Remember, that goes from the SA node down to the AV node. That's your P wave. QRS is through the ventricles, and that's much more complicated because if you remember those lectures where we see that conduction, it's going through the bundle of His, down through those bundle branches, and off on both sides of the ventricles into those Purkinje fibers. So it's a much more complex process going in a much larger area. So first of all, for QRS, are they there? Sort of like the P wave. Do we see a QRS? Yes or no? Simple question. Second question we ask ourselves is there a QRS after each P wave? Because there's certain kinds of blocks where we might have a P wave but no QRS. So is there a QRS after each P wave? And third, do all the QRS complexes look alike? The reason we ask that is that sometimes we have a P followed by a QRS, but different looking QRSs. That's called the morphology, the shape of the wave. And that tells us about how the electrical impulse is being conducted, what path it's taking. And sometimes, even if I felt someone's pulse and they have a regular pulse, there can be an aberrancy that's happening where the electrical impulse is aberrantly being conducted, and we see that different morphology, a different shape. And electrophysiology really helps us to understand that, and that tells us about what might be concerning in terms of electrical conduction through the heart. So those 3 questions with the QRS. 1, are they present? No QRS, no ventricular conduction. Problematic, right? Because we don't then have contraction of the ventricles. No cardiac output with that. So do we have QRS complex? An example of a rhythm where we might not have a QRS complex would be asystole, right? And then ultimately, do we also have a QRS that follows each P wave? So each P wave has a QRS that follows it. Really important, because sometimes we can have rhythms where there's a P wave that is blocked, that conduction gets blocked, and it's not moving through to a QRS. So does a QRS follow each P wave is the second question. And then the third one, do the QRS complexes all look alike? regardless of what they look like, do they all look the same? At this point, we're just going to say, regardless of what the QRS looks like, do they all look the same? And if you remember from my lecture, so for example, we call it a QRS, but there's not always a Q. We call it the QRS complex, even if it goes from the isoelectric line straight to the upward deflection to the R wave. Now we look at our T waves. And if you remember, P is the depolarization of the atria. QRS, depolarization of the ventricles. And then the T wave is the repolarization of the ventricles. And the repolarization of the atria is buried. So much is happening with that QRS, where there's all of that interesting rhythm strip, that we don't see the repolarization of the atria. So for the T wave, now these questions should start to sound alike. One, does a T wave follow each QRS? Okay, so each QRS complex, is it followed by a T wave? Two, does a P wave subsequently, after the T wave, and there'll be like a break, do we subsequently have a P wave? Okay, and that's for the next cycle. So does each T wave become followed by a new P wave, part of a new cycle? And are the T waves upright? So is it a positive deflection? So we go up from the isoelectric line, and are they of normal height? So really peaked T waves or very elevated T waves are really important indicators of things like electrolyte imbalance or cardiac ischemia or cardiac, very significant cardiac injury. So we really want to watch that. And are there U waves present? And a U wave is going to follow the T wave or be buried in the T wave. And so we watch for a U wave, and if there is one, we note the height of the U wave, and if it's positive, so is it upward or is it negative, downward? Okay. Now we want to look at the intervals, right? And if you remember, an interval is the wave plus the segment. And so the intervals become when we come back down to that isoelectric line. So we're looking at the intervals and also just the segments themselves. So the PR interval is from the beginning of the P to the beginning of the R, so that includes the whole P wave. We come back to the isoelectric line and the distance it goes to the beginning of the QRS complex, whether that comes down for a Q or goes straight up into the R. We look at the QRS, the beginning of the Q, whether or not there's a Q, that first deflection off the isoelectric line, and that whole complex, QRS, and when we come back down to that isoelectric line. The QT interval, and do you remember intervals include the wave plus the segment, and so that is the beginning of the Q, whether you come down in a Q or you go straight into an R, we call it the same thing. The Q of the QRS all the way to when we come back down to the isoelectric line, hopefully, and then right before we start that upward deflection for our T wave, so the QT interval. And then finally, we look at the ST segment. The ST segment is really critical for us to look at because it tells us about, if it's depressed, it tells us about ischemia, it may tell us about if we have acute damage, so an MI or some other kind of mechanism that's depriving the heart of oxygen, either in ischemia or actually causing very significant damage when we have an elevation. So that ST segment we really want to pay attention to. Okay, so now we need to make an interpretation. Interpreting the rhythm means that we specify at the beginning what is the site or the origin of the pacemaker of the rhythm. So is it a sinus rhythm, and we'll talk about that in class as we start to go through rhythms. Starts with a P wave followed by a QRS. The P is upward, typically upward, and we measure the distance. We talk about the mechanism and the ventricular rate. For example, we would say if it's a sinus rhythm, it's starting in the sinus node, and the rate tells us that it's a bradycardia, and we would actually state that rate. So here we would make that interpretation, sinus bradycardia at 38 beats per minute. And then we would look at the patient's presentation, because remember, everything comes back to cardiac output. So how is the patient tolerating that rhythm? So different kinds of patients in a sinus brady at 38 could be either critically ill with very compromised cardiac output. Or you could have a patient who's really tolerating it quite well. That doesn't mean we don't do anything about it. But some patients, now as we're getting to 38, that's pretty bradycardic, but some patients are able to tolerate a much wider range because they've got those compensatory mechanisms that are kicking in even temporarily. So we make an interpretation based on that systematic process, and that's the end of what we do. And it's really important to, again, highlight, we go through the process always the same way. We make an interpretation at the end, and then we need to act on our interpretation based on whether we think that this is a rhythm that is expected, whether there's a change in patient condition, or whether our findings, even if it's not new, seem not to have been attended to. I can't tell you the number of times, and I'm sure Leslie would share, where you see a rhythm strip. The rhythm is actually not new. The patient's been in that rhythm for a while, but nobody has really attended to the fact that this is actually a concerning rhythm. So you're always going to pay attention not just to changes, but to make sure that whatever that rhythm is, you're identifying it, you're making that interpretation, and then you're making sure that if there's anything worrisome about that, the people who need to know. Okay, in class, we're going to carry on and we're going to work through some examples. See you in class.